Good evening. My name is Sandra Samuels, and I am the president of Jamaica Reach to Recovery. And I know it's no longer October because Melissa put a spoke in our wheel. And so our last uh, webinar was postponed. Let me say postponed. But the thing about breast cancer is that breast cancer is 24/7. And so, not because October is finished, we had to end our podcast. So, we had one more in the series left, and I promised you that I would have brought you another special guest. And this evening, we have Dr. Hugh, excuse me, Dr. Hugh Roberts. And I'm going to tell you a little bit about him shortly. But first of all, let me just say, we went through a very trying period, and I would like to say to, those persons in the affected area, first of all, my sincere condolences for persons who has lost their loved ones. I went to Montego Bay on Sunday, and I saw how terrible the place was, devastated. And I have heard and I've seen all the images of St. Elizabeth and Black River and all the different areas that have been so badly devastated. And, from Jamaica Reach to Recovery, family to your families, we are aware that persons in the areas that are affected are without light still and without water and without connectivity. But the good thing about social media is that this will be saved online, and so the information for everyone will still be online. So we want to say, our hearts are with the persons who have been badly affected by Hurricane Melissa. And the truth is, all of us have been affected, whether we lost a roof or didn't lose a roof or have light or don't have light. We are all affected because a lot of us have loved ones also in the country. And we have sleepless nights. We are not going through what you're going through, but we certainly do understand. Some of us went through Gilbert, so we can definitely relate. So we just want to say, we love you. We continue to do what we can to assist you. We are, our pink run that was scheduled for October 26th has been, was postponed and has been, it's now going to be on November the 16th. That's Sunday, November the 16th. And at the pink run, we will be collecting items from the registrants because we have over 15,000 registrants. And our belief is that if each person carries one item, we can more than supply a total area of food and water and drink and whatever it is, those basic needs that people have right now. So we have put out on our pages, and we are putting out the plea tonight that when you come to the pink run on Sunday, November the 16th, one Coca full basket, and that's our belief. And I'm a Rotarian by heart, and I'm a Rotarian. And we always believe in giving back and serving the underserved and underprivileged. And at this time, we are now serving persons who are out of a home, and they're out of a job. And so this will be a long haul. So we are fully aware that some will have to give now, some will have to give a couple of months from now, some will have to give maybe next year, not maybe next year, some will have to give next year, because from what we are seeing and the devastation that we are seeing, it's going to be a long wait. So with all of that said, I would like to now introduce you to our guest tonight. He is Dr. Hugh Anthony Roberts, and he is practicing at the hospital, which is KPH, and he's also in private practice in Kingston, Portmore, and Old Harbor. The position that he holds is consultant and associate lecturer at UWI. His area of specialization is general surgery, and he's undergrad qualification MBBS, postgraduate qualification DM, which is general surgery. Sorry, and he's a fellow of the Caribbean College of Surgeons (FCCS), fellow of the American College of Surgeons (FACS), and he's the president of the Association of Surgeons in Jamaica (ASJ) since May 2022 to May 2024. He's head and membership committee, Caribbean College of Surgeons, and he is the program coordinator, DM surgery program coordinator at KPH. He's the founder and co-director of the KPH Breast Oncology Service from 2020 until now, and his special interests outside of medicine and extracurricular activities includes tennis, golf, dominoes, and liming. Yeah, I like a good lime too, doc. And miscellaneous info, he is married and has a family life. God bless you for coming on board, Doc. Let them see this wonderful, your wonderful face.
Well, Sandra, I thank you for the welcome, and I should probably record that so I can show it to my wife. One correction: I am one of the founders with Dr. Copeland of the breast clinic at KPH in 2020, but he's the full director of that clinic.
Yes.
And that clinic still is making strides, which is a good thing for Jamaica.
Wonderful. You see, Doc, I would love for you to tell him a little bit about the KPH setup, because I am positive that a lot of persons are unaware that you have a breast oncology center at the KPH.
Yeah, well,
and that's not on purpose. It's just that people who either don't have anything to do with breast cancer or don't have any loved ones going through breast cancer are just plain unaware.
Yeah, so it was founded instrumentally founded by Dr. Copeland, and I was obviously involved to get it off the ground with some other persons as well. But credit has to be given to him because he came back from a fellowship, I think either earlier that year or the year before. I can't remember the exact dates, but certainly he went and did a breast oncology fellowship for I think 2 years. And when he came back, he had a plan to start it. So we started it ironically in October, which is Breast Cancer Month in 2020. So it's been in existence for 5 years. Obviously, this last month was the 5th anniversary. And the whole plan of it is that you try to, if you look at the issues that we're having before breast cancer, it's quite disjointed, So you would operate on the patients or manage them on a general surgery firm. And then they would go off to get hemo-oncology, or then they may go off to get radiotherapy. And sometimes they get lost in transition, either because they don't come back, or sometimes the instructions aren't there for them to come back. So if you look at a lot of first world countries who have the resources in terms of financial, when it comes to where they have a mass of cancer patients, it's probably best managed at a cancer center. And we don't have a cancer center, which is something that we think that Jamaica is overdue. But obviously that calls for resources, both human as well as physical resources, which require money. So what we decided to do was that at KPH is that we looked at a few cancers or a few diseases that we had, and we tried to say, okay, well, let's, instead of having them all be focused in the general surgical clinic, we can put them aside. So, and that's where breast cancer being the number one cancer amongst females,
it
was a no-brainer. There's also a talk about starting a colorectal clinic, but again, that's human resources. And then outside of the cancer realm, we also have a vascular fistula clinic, because we have a lot of patients, as you know, that have chronic renal failure who are on dialysis and require vascular access. So those are examples of some that are in the works, as well as some that are existing on the breast cancer oncology service is one which happens on a Tuesday morning every week, barring the clinic being closed like for like Christmas holidays, or if there's actually a vacation that falls, a public holiday that falls on that day. And it happens at KPH every Tuesday morning, starts around 8 o'clock in terms of registration of patients. And it goes up to around 2 or 3, depending on the number of patients that are there. And it's still somewhat involved because the clinic is run through my firm,
Right.
which is firm 2 at KPH. So as a result, what we have is that the patients from that clinic are then operated on our list, which is actually one of the issues that we're having right now. So we've solved the problem by centralizing the patients and also having multidisciplinary meetings so that there's a heme oncologist, there's a breast oncologist, there's general surgeons, there's radiotherapists that are involved to discuss patients that are referred to the clinic, which involves not only patients within KPH, but all across the island. And it was mainly to try to streamline and have um, the best care that's available locally. Uh,
Mm-hmm.
in terms and a consensus, meaning it's not one individual that's making the decision, it's a group decision, in terms of the management of patients. And so far, it has helped in terms of coming up with one, plan of how the patients are managed, and two, you found that it actually cut down the wait time from when patients are referred to being seen in the clinic.
Wonderful.
It also cut down the wait time for when patients were being seen in the clinic to when they may start treatment with regards to especially chemotherapy,
Mm-hmm.
where we've cut some patients down to get starting treatment after being seen in the clinic to like a 2 to 3 week period. And sometimes the limitations is not the human resources, sometimes it's the actual drugs, or in some cases, the patients getting the port. But certainly, we can get them to see the heme oncologist within a 2 week period once a plan has been devised. The issues that have arisen, and I can speak with this even though I'm not actively in the clinic,
Right.
is we have now a waiting list for surgery. And you have to remember that even though we have a breast oncology service, we are it's still being is a subset within the general surgical service, even though there's a separate clinic. So what you find that's happening is that the wait time for surgery sometimes is a little bit longer. And because we are piling our list with these breast cancer patients, it means that time being finite at any hospital, it means that some of the other cancer patients may have delays, and you also find some of the other non-cancer urgent cases are being delayed as well. And it comes down to you can't pick and choose, because if I decide, okay, well, we're going to reduce the breast cancer patients, it means then to increase somebody else, the breast cancer patients will suffer. So somebody will suffer. So what we really need to have is either a separate list for the breast cancer patients, um, and that means either increasing the number of lists that we have at KPH, which then would be a physical space problem because we don't have the theaters, I can tell you, are maximized as it stands.
Mm.
And that's one of the reasons why you hear a lot of persons, including myself, saying, hey, we might need to just get a cancer center, not only for breast cancer, but we do have data locally where we know what the incidence and prevalence of many cancers are in Jamaica in terms of the top ones. In men, it's certainly prostate, colon, lung. In women, it's breast, colon, lung. And if you want to throw cervical in there, even though we know the rates of cervical have significantly decreased because of the success of OBGYNs
Right.
in screening with pap smears and the vaccines that exist and education. But cervical is still high. It's just nowhere as high and rampant as as it was 30, 40 years ago. So if you are able to manage those clinics on those patients in one place, and I'm trying, I'm trying to be as apolitical as possible, Sandra.
Yes.
I'm just going to use something hypothetical that has clearly been discussed. We have St. Joseph's Hospital, which is no longer a private hospital, as you know, it's fully taken over by the government. In fact, you're probably aware that the radiation center is based in the government system is based at.
Yeah, but many times it's down too.
Right, yeah. Well, that's another conversation, but
Mm-hmm.
certainly it's there. And obviously, St. Joseph's had 4 functional theaters back in the day when it was a private hospital, and it was and they have obviously wards there as well. So if you can use that to resurrect, I'm just using this as an example.
But I think if I'm not mistaken, I think that's the intention. I
Well,
think that's where they said they're going. If I heard correctly, I think that's the intention. Notice I said the word intention.
I would change the term and say has been strongly considered, because
Right.
there's also been other plans for St. Joseph's as well. Because overall, not to stray away from breast, but KPH has seen better days. The biggest issue is that the population to some degree has outgrown KPH. And if you've been to KPH, you know it's not like the university hospital where they do have space and you see the renovations and new buildings being built at university. KPH doesn't really have any physical space to spread laterally. The only way you can spread
Oh.
space in KPH is spread upwards, right? And by KPH, I mean KPH and Victoria Jubilee Hospital. The space is limited to the point where it's a lot of, for staff to park in the morning, it's a fight, So it's overgrown in terms of resources, both from the staff resources, there's a lot more
Mhm.
staff, and it's overgrown in the sense that you have a lot more patients at KPH because it's still the primary referral center of Jamaica.
Right.
The two major hospitals in Jamaica, especially sadly now that Cornwall Regional has even been further reduced as a Type A, is the Kingston Public Hospital and the University Hospital of the West Indies. And the University Hospital of the West Indies has a strict bed number protocol. So if they go over that, they will refer patients down to us, which is not regular. I should say it's a lot decreased as it was 10, 15 years ago. So congrats to them. But
Mhm.
as you also know, the difference between university and KPH is that KPH is a fully public hospital, whereas university, there's still user fees that have to be paid. While the cost and the prices are significantly subsidized or significantly lower than what you see in private practice or in private institutions, you will recognize that you still have to go into your pocket to pay at the university. So a lot of persons have taken the option of going down to KPH if they have a choice between the two hospitals because of financial constraints. So we still have a lot of work to do, but I think
Mhm.
overall there has been strong positives with regards to the breast clinic at KPH. I would also say since the our inception of a breast clinic in 2020, Dr. Stephanie Leo, along with Dr. Cornwall and Dr. Michelle Walker Bremer. I'm not sure if Dr. Pratchett Roberts is involved, but certainly, and Professor Mitchell at university. But they have, actually started a similar clinic at the University Hospital of the West Indies at the Women's Center there.
Right.
And obviously, we're all friends, so there's good dialogue. What the advantage that they have, as you know, is that they also have a 3D mammogram. So
Right.
it was there from
Yes,
before
Dr.
that.
Cornwall spoke on it.
Yeah. And if you look at the latest guidelines when it comes to screening, it doesn't make mention of 2D mammograms, which is what we still have the majority in Jamaica. And it's not saying that they shouldn't be used. It's just that if you have advances in technologies, like if you look at what TV, if you go into any store right now, you're not getting every TV that you go to try and buy
It's a
nowadays is a
smart TV now.
smart. Well,
High
yeah,
def.
it's a high def
Mhm.
smart TV. Whereas a smart TV, 5, 6 years ago was a luxury or an extra addition, but it's a standard now. So,
Right.
and I think I can't say exactly how many 3D mammograms we have. And I should say that the mammograms that we do have in the public sector, which is only a recent addition since 2023, they are still functioning as 2D mammograms. They do have the software that you can use the 3D mammogram package to enhance the imagery, but it is not available in the public sector. That's number one. Number two, the mammograms that are available in the public sector are only used for diagnostic purposes. So in other words, if somebody has a problem and you're actually doing a mammogram on them. So they're not being used for screening, whereas the university one is used both for screening as well as diagnostic purposes. And I'm not going to go into Dr. Cornwall's realm, but she will, I spoke to her before
I
she came
think
on
I'm not sure if people understand the difference between
the screening.
screening and diagnostic.
So screening is what we advocate for women who don't have any symptoms, and your biggest risk is just your age. Um,
Mhm.
for the average person, obviously, persons who are high risk may have a family history of breast cancer, or they may have been exposed to radiation to their chest wall for some other reason. Or we can use, permutations where we can find out if your risk is more than 20%, so high risk patients, I would put them aside because they are actually the subset. They're still very important. And if you're going to undergo screening in a high risk patient, you definitely should see a general surgeon or a breast oncologist or a surgical oncologist so that we can decide when you're going to start and move ahead with screening. But for the
Mhm.
average risk patient, which is a woman who does not have any previous personal history of breast cancer or any family history of breast cancer or any previous history of other lesions in her breast that increase her risk for breast cancer that may have been biopsied before, they should probably start screening around age 40, which is what our guidelines stipulate right now. And that was our last guidelines were published in April of 20 sorry, in around between April or May of 2019, and that was headed by Dr. Limber Simpson, who's the head of surgery at KPH, with a huge task force at which myself, Dr. Cornwall, probably every person that's spoken on your panel was involved in, and that's not only for Jamaica, that's for the region. What we're trying to do now is actually probably have revised guidelines. And because I sit on the Caribbean College of Surgeons, the Caribbean College is actually bringing out revised guidelines that should be published early next year as regards to breast cancer and some other common cancers as well. But what screening really is to trying to pick up a disease either before it has happened or at the early state of the disease. And the key word in this is in asymptomatic women as it
Right.
relates to breast cancer. So it means you can't have the nipple discharge, you can't have feeling a lump, whether it's within your breast or under your armpit. Your breast should be normal.
Mm-hmm.
And the first step in screening is risk assessment to try to determine whether you are average risk, as I mentioned before, or if you are falling into the high risk category. And about 85 to 90% of women actually fall into the average risk category. But one of the things that we need to recognize, there's a difference between mammographic or radiological screening and screening on the whole. Because there are two parts of screening when it comes to breast cancer that a lot of people don't talk about. And that's one, being aware of your breast, which is breast awareness, self-awareness. And two, clinical breast examination, which just means that your breast should be examined by a physician or a nurse who is trained and knows how to examine the female's
And
breast.
what age should that start, Doc?
Well, that should start around age 25 for the average risk in terms of making women be aware of your breasts, of their own breasts, as well as you can have a clinical breast examination that starts around that age. And depending on the individual, between every 1 to 3 years up to the age of 40, which is when the time you start considering doing the mammographic screening.
Mm-hmm.
A lot of the data that we use for screening is extrapolated from North America. And that's the age that that's many of the bodies that we look at, because some bodies actually want to screen at a later age, and they actually sometimes would say that you screen in terms of mammographic screening, instead of doing it annually, you do it actually every 2 years. But we believe that it should be done started at 40, and it should be every year. And what I will say to you is that if you look at the actual data that we have, you recognize that we get breast cancer at an earlier age when compared to our North American counterparts, the USA. So the median age of breast cancer, depending on which study you look at, is somewhere between 52 and 54 years of age in Jamaica. Is around 62 years of age in the States. So that's almost 8 to 10 years in terms of if you cut a line down through everybody, the person who lands at the 50th mark out of everybody, they are almost 8 to 10 years younger than that you see in North America. And
Mm-hmm.
then we have about 33 to 36% of patients who actually develop breast cancer under the age of 50, and a further 16 to 17% who actually develop breast cancer under the age of 40. So the question you should really be asking is, should we actually lower the screening age under 40? Uh,
Right.
and I am a fan of that personally. The problem
But
is,
then we have the density of the breast to deal with. What?
correct, well, you have the density of the breast. And believe it or not, increased density in the breast actually puts you in some institutions as a high risk individual, right? And you know that amongst the black population and amongst the Indian population, the density of the breast age for age is a lot higher than that seen in the Caucasian population, where a lot
Yeah, I
of the
didn't
studies
know that.
are related.
Didn't know that, Doc.
Yes. So, and we do have a higher incidence, and this is anecdotal evidence here, of dense. If you speak to the radiologist, you speak to Dr. Cornwall, any of them, Dr. Michelle or Walker, Bremer, any of them, that Dr. Shah, Dr. Palmer, the list goes on, because there are thousands, not thousands, but there are quite a number of radiologists that do imaging. Dr. Leslie, the list goes on. I keep on thinking of people in my mind and names are just popping up.
Mm-hmm.
They would tell you that they have seen quite a number of dense breasts, and the 2D mammography is less sensitive of picking up lesions in the dense breasts than the 3D mammography. So the first thing that we really need to do, which obviously is a huge financial constraint, is to improve the actual machines. And when we were looking at sourcing mammograms for KPH, even though the machine that we have is different to the one that I was looking at, one of the more common brands, I remember the quote that I saw was over $500,000 US
Mm-hmm.
for just the machine, not even including like the maintenance over 1 year, as well as the software, which is also expensive. So it's a huge investment, and the price is obviously going to be the same or even more in the private sector. So you are asking persons to improve their technology, and they have to figure out a way of getting that money back. Because obviously in the private sector, even there you have huge competition. There's only and mammograms range probably between 8,000 Jamaican dollars and upward to about 30,000, 30,
Mhm.
40,000. And that 30, 40, as you know, is probably more so when you're doing the 3D mammography, right? So there's only so much you can charge before you can actually see returns on your quote unquote investment for the machine. And I think that's one of the constraints that we do have, because we'd
I was
certainly
gonna, I was gonna say because you had said a while ago that we have quite a few radiologists in Jamaica, but what from where I sit, that's not what I'm hearing. I'm hearing that there are not enough
so there's all
radiographers and radiologists in Jamaica, and then we want to touch on the fact that because it's so expensive to set up, you have areas like St. Mary, Portland, Hanover,
Hannah.
Westmoreland, those areas
Mhm.
that have not yet had access to mammography. So
Correct.
how can we balance that as a country? Because if we have 14 parishes,
Mhm.
I believe every parish at least should have access to mammography if we are going to try to get persons to be spared based on early detection.
So let's go back to what we talked about with screening, and I'm going to bring up
Yes,
the radiologist aspect as well that you mentioned.
yes,
The first thing with screening is that we have a voluntary screening program as opposed to a nationalistic screening program. And that means that we educate people, and you, Sandra, have the choice whether you want to undergo screening or not.
right,
Look at the last population census, and let's use the age of 40. It means that approximately around 400 to 600,000 women are over the age of 40, and that's a conservative estimate.
right,
Understood? If you were to screen, because remember, screening continues in those women. So if you get start screening at 40, you are still in that number at 41, at 42, at 43. So you can use that number. So let's say 600, and I'm using 600 because they're 12 months in the year.
right.
So that means that you have to screen 50,000 people. If you're going to screen every single person, you'll screen the same number of people per month. So it means you have to screen 50,000 people. Currently, the institution that's undergoing the highest number of screenings per month is the Jamaica Cancer Society.
Mm-hmm.
And they are well ahead, right? They are doing, I can't remember the exact figure because Shirley Brown did tell me this, but they're certainly
Mm-hmm.
screening more than around more than 100 persons. I think it's either a week or a month, but let's just use the
I
better
think
part.
it's per week. I think
Let's
it's
say they're
per
screening
week.
100 per week, right?
Yeah, I think it's
Yeah,
25
yes,
per
actually,
day.
yeah, it's 100.
It's
It's around.
25 to 30 per day, if I do recall correctly.
Let's use the upper figure of that 150. So that's basically 600 per month. We have to be screening around 50,000 per month, and they're screening at the most, and that's 600 per month. Understood? And they're screening every day for 5 days, barring the machine going down.
Sometimes I screen on Saturdays
Right? But you understand the point in time I'm
to
making too,
catch up.
right? So the shortage that you are talking in radiologists and is because we don't have enough machines. But as I did a last again count, which I would say is probably around 80% accurate,
Mm-hmm.
because there are probably one or two machines and that I am unaware of. And this is me speaking to radiologists and
Mm-hmm.
calling institutions. You are correct, one, that there are 4 to 5 parishes, God forbid now with the hurricane in the west, that don't have access to mammography. You are also correct in the sense that there are probably about 25 machines in Jamaica, but more than half of those machines are located in the Kingston, St. Andrew, Portmore / Spanish Town area,
St. Anne.
right? And right, that's where they're primarily located. And then if you go to the North Coast, there's a huge pocket. What I mean huge, relatively to the number that I'm talking about, in St. Anne, around that St. Anne's Bay, Ocheries, and then another pocket in Montego Bay. And then the other areas are where you'll find scattered 1 or 2 machines, right? I think Mandeville may have 1 or 2 as well, but certainly, as you rightfully said, there should be at least machines in
At least one.
parish, right?
At
Because at the
least
end,
one.
correct, at least one machine. Now, even if you were to increase the radiologists in Jamaica, and there are quite a number, so kudos to the DM surgery program, because there has been a significant um, exodus of radiologists who have graduated.
I'm happy to hear
Majority,
that.
no, the university is graduating radiologists. Where the problem is that a lot of the radiologists aren't in the public sector, right? And remember, in private, if I want to send a patient to get something done in terms of screening, I can get a date. If I saw a patient today, which is what happened, I can get a date for that patient next week to get screened easily. I can
Yes.
get a patient, I could pick up the phone as I was in office yesterday and get a patient to get an appointment by the end of this week to have a diagnostic procedure done. The problem is the access to screening for the majority population who may not be able to afford it or who have to stretch to afford it, especially where this is something that's being done every year. There is no screening available in the public sector. The Jamaica Cancer Society has a good partnership with some of the other radiological centers that help to cut costs and they go and send the patients. I think all of the radiologists are pro screening, but we do not have enough machines, right? We
But
may not,
but in the public sector, there's only one at KPH
and
and
one
one at Cardwell Regional.
and I don't know what the status now again with what happened last week Tuesday. And again, as I said, those machines are only used for diagnostic purposes, meaning somebody has something wrong with them, or somebody's undergoing surgery, and like let's say like a radioactive dye needs to be placed, or you need to re-image the lesion to make sure you're doing the right operation. That's what that machine at KPH is being
Ah, that's what you're saying.
right? And when I speak to Dr. Palmer, who is the head of the consultant, who is the head of the department, and I'm proud to say that because for years Dr. Palmer was the only person. Right now, this year, two other consultants or post DM trained radiologists were added. So they've increased the number of radiologists by 200 from one to three at the premier center referral center in Jamaica, right? So the radiologists, when I have to go and speak to them because of a problem where my residents are having problems getting a procedure done, I feel like I have to walk in there with a gift to get it done because they're stretched. They're not only there to do mammograms, they're doing CT scans, ultrasounds, actual interventional procedures. And what people don't know also is that the unit at KPH is also used on a Thursday to do patients from Bustamante Children's Hospital that have to come down there to have CT scans done. So we are, if you think
Stretched
statement,
is an inadequate word.
yeah. So the good thing is that I think for the most part, um, you're trying to get everybody involved, but for the most part, a lot of the patients that we see can go and get their investigations, like the ultrasound and the mammogram, done outside, and the ultrasound is still available in every hospital. I would say there are ultrasounds in hospitals. The problem is getting the mammograms done. You know,
Right.
so that's one issue clearly. When Dr. Cornwell will probably tell you there's a shortage of radiologists, she's right, but the shortage is nowhere as severe as the shortage of in the public sector, and is nowhere short as the number of mammographic machines that we require right now to get an acceptable number of women screening, which is under 20% of the population that should be screened.
Which is untenable.
Yes.
Untenable. 20% of the public with
And that's,
with,
and that's,
with
that's
breast cancer being the highest rate of cancer in our women.
and that's the 20% of that 400 to 600, not 20% of the half of
General
the
population.
population, because clearly women under the age of 40,
Lord,
right, aren't in this bracket unless they're high risk
Doc,
patients.
you're stressing me. You're stressing me.
I'm not stressing you, Sean. I'm talking things because the fact of the matter is, and it's not a political statement because I
No, no, no. We know that that's why we're having this conversation, Doc, because the truth is that I've said it on this program already. The fact is, the only reason why I know, and many of us in my team know, is because we have had breast cancer,
yeah,
and we constantly have persons coming in telling us their experiences. This
yeah,
is not about politics. This is not about who doing good, who doing bad. This is straight facts that something needs to, as I like to say, it need crowd.
yeah,
It need crowd because these are things that have to fix. I mean, money or no money, it have to fix because when a woman drops out of the picture of a family, the family suffers badly. And so these are some of the things that, one, we need to talk about. Two, we need not to talk about it only in October, because breast cancer is 24/7.
Yeah.
And that's why I chose not to not have this conversation with you, because just because October finished, because we need, one, the word to drop on the right ears, whichever ears that is, and two, we need women to be aware that we have to be proactive, one, about our health, and two, know, we need to know where to go to get the treatment, and to be aware of the next thing I want to get to is the cost, because as you say, the public sector is overwhelmed or really full, and you have to wait to get your surgery done or whatever, and we understand that a lot of people don't have it. So what does one do when they live in Montego Bay, or they live in Westmoreland, or they live in Portland, or they live in Hanover, or they live in St. Mary, any of these areas that don't have access to a mammography? So the person in St. Mary will now have to go to Ochi. And we pray that the machine in Ochi is working. Because that's another thing. Sometimes you call, the machine's not working in some of these areas, right? And so it's a challenge, and a challenge that must be discussed, you know, because the one, you have to pay bus fare. You don't have the money already, you have to pay the bus fare. Then if you do find out that you have breast cancer, then that's when the money really start rolling in, if you can't go public. That's all.
Yeah. So I think it was last year. 'Cause I present at the Jamaica Cancer Society's forum every year with breast cancer, and instead of doing the usual things, I try to go off the path, talk the things, and I investigated, and I thank my colleagues for giving me this information. How much does it cost per stage for breast cancer?
Right.
And I
Right.
compared stage one, which is what you call early stage, which is where if screening works, you want to pick up the disease at stage one.
Mm-hmm.
And sadly, we have too many women that are presenting to us at stage three, actually three times the amount that you see in USA, right? Which is too many, which means screening is not
And
working.
you would say that that has to do with what? Lack of knowledge, lack of access,
Both,
lack of money,
everything you said.
oh, all of the above.
Lack of knowledge, meaning that, and it's not only a lack of knowledge, because I think some women do know about screening,
And fear is a main
and they
factor
have the
there.
fear, or as you said, they don't have the access, which means finance, and the access is because of financial means. Because you could live in Hanover and you have a car, you can drive to Montego Bay, right? But a lot of access really comes down to finances. There's a cultural fear that everybody has, believe it or not.
Yes, yes.
Everybody has, and that's not an educational level. That is
Right,
from the less educated to the Rhodes Scholar,
right.
right?
Agreed.
I've seen all patients, women who are in the most powerful positions of their company and stuff, who quiver, and I
Right.
understand because, right, but it is mainly that screening is not being done while you have so many people being picked up at stage three. There are some patients who do present, and a significant number that do present with stage three, and they knew they had a lump. They knew that they had a lump from the time it was small. And, cultural beliefs, sometimes getting the wrong advice from a neighbor, because there's nobody in the medical fraternity, whether it's a nurse, a doctor, a radiographer, a radiologist, anybody, they're going to tell you at least to seek medical attention. If anybody comes to you guys, you're not going to tell them to just wait and see, you know. Um, And then the other thing, which is a cultural problem as well, is sometimes you will see patients when they're stage one or stage two, where the outcome is favorable for them, and they're gonna go and spend $1 million to
Yes.
get a bush tea, to get a bush tea, um,
Yes.
and then come back to you when it's now stage three, or even a metastatic disease, which is stage four, because they had spread to
Yes.
vital organs like the bone, the lung, the liver, and sometimes even the brain. So those are some of the issues that happen. But when we looked at the study, we found that the overall treatment for stage one, and obviously there's going to be a wide variation because it also depends on your receptor status as well as what type of surgical procedure you did, whether it warrants radiotherapy afterwards or not. And it ranged from around 2.7 million Jamaican dollars all the way up to 5 million for stage one, which is still
Mm.
significant, right? And obviously, there's some that may extend more. Like, for example, if you were triple negative and you had to get radiotherapy, if you underwent wide local
Or
excision,
septin.
correct. There are all of those factors that come into play too. But when you compare that price with the price for stage three is going into double digits of millions
Yep.
of Jamaicans. And it started in the figures that I compiled around 7 million, 6.7 million, and it went all the way up to 14 million and can again go beyond because that does not include if the patient had any recurrences. That does not include if the patient had any resistance to the baseline
The
chemotherapy.
treatment that you
Well,
started.
you have to add a second line. It does not include immunotherapy, which sometimes runs you in the millions per month, right? So it is an expensive form of treatment. What do you take away from that? One, obviously, we've spoken about screening because we can see that the stage one, even though it's expensive, is a lot less expensive than treating advanced cancer. But the second thing that I would always advise to patients is that insurance pays. And we have fewer than 20% of the population. The last figure I was quoted was 17.2% by one of the insurance companies that have local insurance. And what a lot of people also recognize is that they work with a company that has insurance. They leave the company and they have no insurance after that. So they've been
Right.
for insurance in their earlier ages of life, like between, let's say, when they started working around in their early 20s with a company for 10, 15, 20, 25 years. And then at 45, when all they've used the insurance to do is to go and get an annual medical checkup, get some pap smears, some blood tests, probably get some
Right.
glasses, probably go to the dentist, which is, as you know, minuscule money relatively. And then after those 45 years after those 25, 20 years of contribution, they leave the company, they're back to stage zero with insurance. So even if you work with a company with insurance, I always tell patients that you should try to get your own personal insurance, even if it's not as strong as the company's
And the
insurance.
critical care policies that they
Right.
have
And
now.
also get a critical care illness. And the younger you get it, and this is not an insurance talk, but this is
Right.
this is
I tell
really
them all the while.
get a
Yeah.
critical care policy because once you are diagnosed with cancer, that and you have the histopathology report from the biopsy, not from even the surgical specimen, from the biopsy. And this is not only, as you know, for breast cancer, and you have a critical care package that will be paid out to you in no time from the insurance companies. So I think that's something that people should be aware of because a lot
Right.
of
Because
Jamaicans
once you
don't
get
have
the
insurance.
cancer, you can't get the policy again.
No,
So you need to
and
get it when you're up and about and healthy and hearty
yeah,
and can get it. And the premiums are lower too when you get it earlier.
correct. And you're talking about insurance coverage that will cut off sometimes 80% of the cost. Um,
Right.
and what you have to also remember is that there are a lot of programs, both private and public. So the biggest one that the government has done is the NHF fund,
Right.
the health fund.
That has
Which is,
a lot of help with the medication.
so you get a lot of help with that. There are other entities within the government system, such as the Chase Fund, that patients would have access to. I'm not access doesn't mean that you would be granted the payment,
Granted it,
but
right.
you can apply for it. There's a compassionate fund again, also through the Ministry of Health.
Ministry of Health, yes.
We also have to give credit to, like, for example, Rush, Stacey Ann Daly,
Right.
because Rush locally and through their Latin American offices does a lot for breast cancer and subsidization of drugs, one. And two, the new receptor machines that one is placed, as you know, at the University Hospital and one is at the National Public Health Lab. Again, through the NHF program, allows all patients who are having receptor status done and who have a valid NHF card with breast cancer attached to it to allow that to be given to them for free. And the actual cost for that is around $12,000, which is still a subsidized cost for receptor status,
Absolutely.
right? And to put that in perspective, when you send those same specimens overseas, because there is
Hmm.
a slight limitation when it comes to, like, for example, when you're testing for one of the receptors, which is HER2 new, if you are equivocal, unfortunately, we're at the stage where we still have to send that overseas. And that's a minority of patients to actually see if they're positive or negative. But when you send receptor status overseas, you are starting at $250 depending on what lab you're sending it to and what type of panel you are sending. And then you also have to pay another $10,000 to $15,000 courier fee to get it there. So I think you have, well, we talk about the deficiencies, we have to also applaud the successes. So there are partnerships, and we've talked about the Jamaica Cancer Society already. You know,
You had mentioned, okay, so with the test, because I've been asked it several times, and I always say I must check it out. The BRCA test, is it done here?
so the answer is yes. You can take the specimens here, and they
And
are
send it overseas to be tested.
overseas. I know that. I don't want to speak out of turn, but I know that for the breast oncology clinic, there is an arrangement where it is done here. And I'm not sure if it is part of a study that's ongoing. But certainly you can take the swab, sir. It's just a mouth swab. I mean, there are other ways you can do it, but you can just do a simple mouth swab. And the advantage of testing for the BRCA1 and 2 gene is that's not, in most cases, that's not the only thing in the panel that you're testing for. There are other genetic mutations that you're also testing for that are also affect some breast cancer patients and put patients at risk for development of other cancers. But you don't have to travel overseas to get it done.
To
It
get
can
those
be
things
locally
done.
in Jamaica. And I do know that there is a local lab here that is also thinking about having it done, especially where not only again for breast cancer, but for colon cancer and many other cancers. Genomic and genetic testing is a big part of the treatment of these patients when it comes to additional drugs, such as the hemo-oncology drugs that the hematologist gives, like chemotherapy, as well as the immunomodulators that are slightly more expensive drugs, as you know.
All right. So since we're talking about overseas and Jamaica, and let me just say to our friends online, please remember that we are on StreamYard, which allows you to ask questions by the chat. So you can go in our chat room and ask any questions that you want to ask, because these are the reasons why we do live, because we could easily tape and send out this video, but we want it interactive. So we want you to ask questions. This is why I bring only experts on this platform. I only bring experts or persons who have a working knowledge of what we are talking about. I myself is a 26-year breast cancer survivor, so I know a lot of the questions to ask. Plus, I'm the president of of Jamaica Reach to Recovery, which we are 150 strong, and we meet every second Tuesday of the month at Webster's Memorial Church Hall. So we have new people coming in every day with various different questions, various different types of situations. And so we are, when I tell you, so we have a wealth of knowledge and a wealth of experience. And so when I talk to Dr. Roberts and I talk to Dr. Copeland and I talk to Dr. Cornwall, I mean, I can safely say that I am almost, I don't get the medical degree, but I am off fair with a lot of the information. But I don't want to have the information for myself. I want to bring the information to you so that you can make an educated and calculated decision when you have your decisions to make. Because I think, Doc, most of the times, the reason why fear creeping so badly is because we don't know. We are dealing with something that we have no knowledge of. I mean, I remember back in the day when 26 years ago, when I had breast cancer. I mean, people were hardly ever speaking about breast cancer. Now we have various different forums. I mean, people are talking about it openly. People are giving their experiences openly. Doctors are speaking about it openly. So we are in a much better place. Plus, there's always Google. Not that we want to Google any site. You're going to go on trusted and accurate sites like maybe the American Cancer Society site. Is there any other site that you can recommend, Doc, that we can also
Yeah, so there are many that come up.
But
Anytime you Google, you're gonna see some of the major hospitals, not only in North America but across the world, talking about the management. What I would say to patients is that patients have full autonomy. The doctor is not the boss. The actual patient is the boss, and you have to. My mother always said to me, there are four persons that you have to have a good relationship with in life. One is a pastor or whatever spiritual person that
right,
represents your church or your mosque or whatever religion you are. One is your lawyer, one is your accountant, and the other one is your doctor, right? And the reason being is that you are talking about something that you have no knowledge about. Because I whether you could say fortunate or unfortunate, I've been a patient, and I understand to some degree the fear that goes through of being a patient. And at this stage of life, I think many doctors themselves have been a patient, depending on the severity of the disease that or whatever's wrong with them. And when you are in that position, you recognize you know how you feel as a physician, where you have
right,
more than average knowledge of the situation. So imagine you have a non-medical person sitting down there who has no knowledge and they have to trust you. So I
right.
think patients have the right to ask any questions. And as I say to my patients, if I can't answer a question, it's one of three reasons. Either the answer does not exist, right? Or if you ask me a question and I can't answer, it's because the answer does not exist, or the answer is unknown in the medical fraternity where there are options. And I think every patient should have the right, if he or she asks, because it's not only breast cancer affecting, as you know, women, right? And there's
Hmm.
a minority of men too. You should ask for a second opinion,
Right,
right? You can ask for a second opinion. No, 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 no. I've had many patients come to me for second opinions. I've had patients who've left me and gone to someone else for a second opinion. Sometimes they decide to stay with the other physician. Sometimes when they come to me, they want to stay with me. I just think it requires dialogue between the physicians and also dialogue at the patient. That's
absolutely.
fully clear, because you don't know what experiences patients may have had with other doctors either. So you have to recognize that when they come into your office, even though they're referred to you, which is a good thing or a good starting point, they
Hmm.
may have had bad experiences for another circumstance with another physician. And they may come into you with the fear that you're going to go and tell them to do something from a financial basis versus what is best for them.
Right,
I have patients that have come in my office and said, well, why are you not offering me surgery? Obviously not for breast cancer. And I said, you don't need surgery for this problem. And they said, are you sure? I said, well, I'm a surgeon. I make money from operating. So if I'm telling you that you don't
right,
need surgery, you should at least trust me. Right?
right,
Um, so it's about that. And I think I could say for the most part that that is not a major problem for us in Jamaica and the Caribbean. There's always, one or two bad experiences, but compared
hmm,
to some other countries, as we know, uh,
right,
that aspect is on the low, and I hope it remains low or even gets less in Jamaica.
right. No, Doc, I think, all right. So, as I said, because we're talking about overseas and Jamaica, I know a lot of persons think that, foreign always better. What would you say to the public now about you know access to yes, we know we have a challenge with affordability of access to healthcare in Jamaica and everything, but I don't see where it's much cheaper overseas. Can you just make a little comparison to both, and what in your view, where do we um stand on the podium?
So I think you have to compare apples with apples, right?
Yes.
When people talk about overseas, they're not talking about Broward County Hospital. They're
Right.
always making reference to the best, the John Hopkins, the MD Anderson, the Mayo Clinic, the Sloan Kettering, um, just to name a few.
Right.
The first thing is, if you're going to compare those, then compare those with the best of the best in Jamaica.
Right.
And there's no difference in terms of the surgical management. I think our hemoncologists are very knowledgeable, and the
Mhm.
drugs are also available. A lot of the difference that you're going to have is not the human resources. A lot of the
Right.
difference that you're going to have is, one is the physical resources. We might be behind, obviously, when it comes to some technology that you would again only see in the big centers in the states, but
Mhm.
we are catching up when it comes to those things. Um, So I have no problem with patients even having a hybrid system. If you're going to come to me and say you require a mastectomy and you're going to go overseas and do it because you feel it's better, I think that is a no-brainer. You're not going to have it done better, right?
Right.
It's equal. And, you know, um, I might even argue that we in Jamaica might be a little bit better because we see
Well,
more
I can't speak to now,
right?
but I can tell you, like back in the day, when I was able to tell my girlfriend some of the things that I was doing, and when she spoke to her doctor, because when I was on tamoxifen, and Dr. Smith had put me on tamoxifen from before I did surgery, because I said, doc, I need some time to sort out my business, so before I go and lie down and have surgery. And he said, you know what, Sandra, I'm going to put you on tamoxifen until, and you're going to be on tamoxifen for about 5 years and yada, yada, yada. But when I spoke to my girlfriend, who she was in LA, and and I mean, she was having a challenge, they were back and forth with her, and I was saying, you're not on anything. And she said, no. And I said, but I'm on tamoxifen. And, they never spoke to you about tamoxifen or anything like that. She said, no. And I mean, after I spoke to her and she spoke to her doctor, she was on tamoxifen. So you see, as you said, to me, I mean, the doctors that we have here, I think they are top class,
Yeah.
and I don't think they're any cheaper in the States.
Well, in fact, what I would say to you is that dollar for dollar, you're gonna pay a lot more money in the States, especially if you
Right,
go to some of the centers that I mentioned.
right.
We can accurately say that the cost in the States is about 2 to 3 times the amount that you're gonna pay for surgery, compared to Jamaica in some centers, and some centers, meaning I'm comparing private practice here with the States because they don't
And
have.
that's unless you have the insurance for overseas as well.
Right. So what? So
Mhm.
that's where I was
It's
going to
not
say
like
now.
insurance.
A lot of persons who are telling you about the states may be cheaper is because
Right,
you are Medicaid. They may have access to Medicaid and Medicare, which is universal. Now you add in Obamacare, and then they may also have personal health care insurance, which tends to have better coverage dollar for dollar overseas than here. There are many locals, but I mean many. It's still a small subset of the population, but the increasing number of persons who have overseas insurance and live in Jamaica is increasing because they're becoming more knowledgeable about it. Obviously, the premiums are significantly more
right,
out, but overall, the coverage is obviously going to be significantly better. The advantage that we have is when you're comparing that system to the public system is that you have very little to pay in the public system for surgery. And well, you have almost nothing to pay for surgery because surgery is actually, I can tell you for the most part, it's free. The adjuncts that you would have to pay is if you have to get the investigations done outside of the hospital system, like the mammogram. If you're doing advanced surgery, where you mean like you're doing a localization technique, you would have to pay for if it's a hook wire, or if you're doing a magnetic seed or a technetium or some of those things that have to be injected, you have to pay for those, but it's still nothing comparative. The issue in Jamaica is the adjuvant treatment, especially that you spoke about earlier about the machine being down at St. Joseph's for radiotherapy. So we are behind in radiotherapy. Again, we have more radiotherapists here now, but we don't have more machines,
machines.
right? So and that affects not only in the public sector, even in the private sector. While the machine is obviously better maintained because they can pay for it,
And
it is
and that cost is about 3.5 million. Am I correct?
you've hit it on the dot. Yeah, it's around 3.5 million Jamaican dollars. Again, covered by insurance, but we're dealing with absolute cost. Um,
Right,
so what I found with some patients that I've seen in private, and I don't try to stray towards the private side in my talks. Um,
right,
Patients may get surgery here if they got the neoadjuvant chemotherapy and treatment. They've got it before, obviously, and then when it is that they need the radiotherapy, the ones who can afford it fly up to Miami and get it, and then come back because they don't want to wait for the timely situation here,
right,
especially in the public sector. In the private sector, obviously the wait is a little bit less, but sometimes you just need to go. The one aspect that I will mention strongly in the difference between wherever you get treatment, and I don't care where you get treatment, as long as because part of health is not only physical, but it's mental and emotional well-being. So if mentally you really strongly feel that you want to go overseas, and that gives you that peace of mind, I will give you the preamble, but I think the patient has 100% autonomy, and I will support you. But what
Right.
patients need to recognize is the support that you get from your family and friends, especially if they are based in Jamaica. So if the converse is true, where I have a patient who actually lives in Jamaica, but they have a lot of family in the States, it might be best that they actually do go up to the States or Canada or wherever they're from.
Right.
Because they would have that support where somebody's with them, somebody can carry them for their treatments when it comes to chemotherapy, plus or minus the radiotherapy. And that support might also be financially because they have somebody they can jump in someone's car to go somewhere.
Right.
They're in Jamaica by themselves. But the majority of patients that we are seeing, their family lives or their immediate family and friends live in Jamaica. And that is something that should be taken into consideration because it's an emotional journey, as you and every person who has gone through it knows.
Mm-hmm.
And the scars, mental scars, are there with you after you've seen me.
Right.
Because you see me and get treatment. After a day or two, you're out of hospital. I will see you, for about 2 or 3 more times in my office for that initial treatment. And then you have to undergo, if you're going to get chemotherapy afterwards, 8 to 12, 14, weeks of chemotherapy.
Mm-hmm.
And then you may have to undergo radiotherapy. So when I see you back 6 months later, you might still be getting some form of treatment, and that doesn't include if you are hormonal positive, receptor hormonal positive, where you're going to be on treatment for 5 years with tablets. And that requires then you having to do visits. Depending if you're a young female, you might have to, and you're on tamoxifen. That means you have to see your OBGYN because of the risk of endometrial
Mm-hmm.
hyperplasia. And if you're an older person who's on aromatase inhibitors, you're going to have to do your bone scans as well, just as, to make sure that your bone density is up to par, and also probably take the medication to try to enhance your bone density, like the Rocaltrate.
Right.
Right. So it's as you rightfully said, it's not that the disease or the treatment stops immediately. You know, as Derek Mitchell used to say to me when I was a student, not trying to age him, but he used to say to me, "You're gonna be my patient for life unless you fire me."
Right.
Right? The only way this relationship is gonna end is either you move on to somebody else, you move on to God, or I move on to God.
Yeah, because I've been seeing my doctor now for the last 26 years.
Yeah, correct.
Because I have to do my tests every year, same way,
Yeah.
you know, to make sure. Good evening, Nadine. Welcome. Do you have any questions? Let me know. So, Doc, all right. So by the time, all right, how does one, all right, I know, um, Rush is putting together, Rush with a group of stakeholders are currently working on the patient journey. But let's say I am diagnosed. No, 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 don't diagnose it. I find a lump, I go to I go to the doctor, any doctor, or I need to go to my my well, let's say I don't have a doctor. How do I start my journey? How do I know what is my next step? And when I go to the next step, what is the next step?
So you find a lump,
Yes.
it means that you should either go to your health center
Mm-hmm.
in the public sector, or you should go to your private physician, like your GP or family doctor.
Mm-hmm.
That's or if in or in both situations, your OBGYN.
And that is immediately.
Immediately. There should
Right.
be no hesitation. Any
Right.
lump you find, no, let me make this categorically clear.
Right.
You see, the chance of a lump becoming cancerous increases as you get older in life, not knowing what your risk profile is.
That's correct.
Overall, the majority of women who have lumps in their breasts, those lumps will come back being non-cancerous or benign
Right.
lumps. I want
So
to
there's
make
no need to panic.
there's no need to panic.
That's correct.
And you go to, so your first encounter is not going to be with me or a breast specialist or a surgical oncologist or even a heme oncologist. Your first encounter is probably going to be with your family physician or
Mm-hmm.
healthcare physician, or it's going to be with your OBGYN. And if you work in a company and you have an occupational health nurse, that's the person that you would go to.
Okay.
And, it's going to start with them asking you questions, which is basically taking a history to see what your risk is and to see if you have any other symptomatology with regards to that lump. Nipple discharge, if you feel any other lumps, when did you feel the lump? Is it painful? Is it painless? There are a barrage of questions that they're going to ask you. And then that person will examine you if they can examine a breast, or they will refer you to somebody that will examine. And the next step should be that you should be sent for a mammogram and an ultrasound. And the mammogram and ultrasound should be the next step after you've had a history and examination. Somewhere in between there, depending on the individual that's seeing you, and most times is that you're going to come back to the physician or the OBGYN or the nurse with those results. If those results show that you do have breast cancer, then that's where a referral should be made to a surgeon. And then that surgeon's next step, obviously, even going through some of the previous things that you've gone through with those persons. So you might be asking similar questions and more again. So, and it means it requires some degree of patience, is to do two things from that biopsy. One, if it's not, one is to biopsy you, right? And if it is that the radiologist saw on the mammogram and or the ultrasound that the lesion is suspicious for cancer or highly suspicious, you should be doing, in our setting, a core needle biopsy. And that's usually under ultrasound guidance if the lesion can be seen under the ultrasound. If it is that, the lesion is small and stuff, you would have heard things like hook wire, but the point is you need, and other forms of biopsies, but the general thing is that you need a core needle biopsy. And why I stress that point is that sometimes the wrong thing may be inadvertently or purposely done. And that is where you have a patient who has a lump that's highly suspicious for cancer, and they go and have an excisional biopsy to remove it done. And that should not be done for a number of reasons. One, it affects what other surgical procedures could be done. Like, for example, the patient may be desirous and fits the criteria to just have the lump removed.
I was going to ask you that question. How is the decision made whether to do a lumpectomy or mastectomy?
Yeah, well, I'm gonna get there with that, right? And two, as you know, there's a subset of patients, depending on the biopsy results, especially with regards to the receptor status and the stage of the patient, which I'll explain what that is shortly, may require treatment with chemotherapy before surgery, what we refer to as neoadjuvant treatment.
Right.
Right. For example, your
And that
patient.
is to.
Pardon me.
And that is to do what?
And that would help to shrink the tumor, and also for us to see the tumor's response to chemotherapy. And from the surgical studies that we've looked at, the scientific studies and data that we've accumulated, we recognize that there's a subset of patients, like the patients who may be triple negative on their receptor status, or persons who may even be HER2 neu positive, that will do better from receiving treatment before with regards to chemotherapy as it relates to surgery. You also find that patients who have, large lumps, they may also benefit, because when you give the chemotherapy before, it can shrink the tumor and downstage it. Where when you first saw them, you might say, "Why, we can't do anything for your bottom mastectomy because of the size of the lump." And now, after you've gone in neoadjuvant therapy, you realize, well, we can consider removing the breast, which is a mastectomy, or you may be a candidate for the wide local excision, right, which is just to remove the lump. So that is one thing I want to stress, that you should do the history examination and the imaging with the mammogram and the ultrasound first. And based on the results of the mammogram, if they show that they're suspicious or highly suspicious for cancer, then those patients should have a biopsy done, and that biopsy in our setting should be a core needle biopsy as the primary choice. I'll be careful how I say that, because in the States, you can do a fine needle aspiration cytology, but a surgical biopsy, such as an incisional biopsy, should only be reserved for second line, and an excisional biopsy should not even be done at all in that setting. When you send off the histology, the biopsy to get a result for the pathologist, the histopathology report will say that you have cancer. And there's information from that we also take into consideration. The grade of the tumor, which means how aggressive it would be. And you also know that it's also going to send it off for the receptor status, which I said locally through the NHF card and through the program with Roche and the government. It's actually free if you send it to either University Hospital or the Kingston Public Hospital. And this also exists for private patients as well. Right? So if the private patients may have had their histopathology done privately, you can still get the receptor states done within public locally, and that will be free once they have an NHF card. And once you get that back, the next step for us with a diagnosis is to stage the patient. And that means that we want to see taking into consideration, things of the tumor, so that the size of the tumor, which is the T stage, if there are any local nodal involvement, meaning spread to the armpits on the same side that the tumor is. And then we also want to do investigations like CT scans to look to see if there's any spread to the bone, the lungs, or the liver. So you'll probably do a chest and abdominal CT scan, depending on what we find clinically at the time of when we examine the lump based on the size. And once we have all of that information together, which takes a few weeks, the next step, as you know, is to devise a plan. And that plan will be usually discussed with a multidisciplinary team. Um, and you're trying to decide not only what type of surgery, because I'm saying this as a surgeon, but you're
Right.
also trying to decide the order of treatment, which might include, does the patient need chemotherapy? Yes or no? Yes. Does the patient need surgery? Yes or no? Yes. Does chemotherapy occur before or after surgery? Right? Then does the patient also require radiotherapy? Yes or no? So that's what we are trying to determine. One, the order of treatment, and then when you figure out the order of treatment, and I speak as a surgeon, then you have to decide what type of surgery is the person going to have. And from a surgical standpoint, keeping it basic, the two areas that we are focusing on as surgeons would be obviously the affected breast with the cancer in it, and two, the armpit on the same side of that breast, because that is one of the first places that the breast cancer will go. And I want patients to understand, or persons to understand, that when you operate on the axilla, which is the armpit, it is not to treat. It is actually done there to get more information, which is prognosis, to see what the possible outcome of the patient will have, which is their prognosis, and to also gather that information to determine what other treatment may be needed.
Needed.
Right? And there's a subset of patients who clinically and radiologically don't have any nodes that we would have found from the investigations that I mentioned earlier, that may not require an extensive axillary lymph node dissection, which is the operation that is done. They may require what is known as, or they may be able to have what is known as a sentinel lymph node biopsy done, which is less invasive and less morbid.
Mm-hmm.
Because everything that you do in medicine, especially in surgery too, you have to look at the benefits, but you also have to look at the risk.
Yes.
And axillary lymph node dissection, when you're clearing the area where the nodes are, there is some risk. There's risk of lymphedema where the arm can swell. And I know you know of one or two patients that have had that complication.
Yes.
There's always a risk to other vital structures that run in the armpit or the axilla, such as nerves that can be damaged and even blood vessels that can be damaged. The morbidity, or when a lot of us, knock on wood, because I'm actually operating on a patient with breast cancer tomorrow, so I don't want to go out myself, but
Mm-hmm.
the complications from surgery are usually low, right? But they can occur, and if you do enough cases, you will develop. It's not a matter of if, you will. I've had
Mm-hmm.
complications, and you will. So
Yes.
it's sad, but it's just how.
Reality.
Yes, the
Nadine says she says she's confused because her surgical pathology report shows that there's no cancer cells in her lymph nodes, but yet she was told that she has to do chemotherapy. Now Nadine had a recurrence because she said she did a lumpectomy in 1998 and a mastectomy of in June of this year. She
So
said her
she had a master. She had a
lumpectomy in 1998, and then she had to do a mastectomy this year in June.
and that's on the same breast, I'm
On
assuming,
the same, yes,
because she had another tumor that came back.
apparently.
So what I would say is that that's not recurrence. That's actually a brand new tumor that came back, right? Because
So she's saying that the lymph nodes did not came back with not what she said. They showed no cancer cells in her lymph nodes. Yet still she's now told that she has to do chemotherapy. Is that
so
because she has it a second time?
no, there are other criteria that I am unaware of. So, for example, one thing that Nadine hasn't mentioned is one, her receptor status, and two, I
She
would
said
mention.
she went to do the receptor test, wasn't done free because the machine was down at
Yeah,
UWI.
so it's not as usual. So let
No,
me
she
let
never
me
said as usual. Said
let me be
she
clear
said
here.
it was just to say it was just down
Yeah,
at
let me
UWI.
defend the people. Let me defend the rush people. It's a lot of times it's not the machine is the problem, A lot of times the reagent isn't available because the powers that may be, the government hasn't paid for it.
Okay.
Right. So a lot of times the machine may be down. It's a scene in my anecdotal evidence that it's more sadly down at KPH than it is at university. And usually when it's down in one facility, the other facility just takes the specimens.
Okay.
But because of the times when I know university has been down, they send the specimens down to National Public Health Lab. Um, but there are other reasons why you get chemotherapy. It's not only because of the lymph node status. And believe it or not, while the lymph node is something that's still used, what is more promoted, but it's a very expensive test, is something called Oncotype DX, which helps to determine if patients will benefit from chemotherapy.
What was that?
Oncotype DX. It's based
Bronco?
Oncotype DX.
Onco
DX. Yeah,
Okay.
and it's quite expensive because it's new. It's around $4,000 US.
Woo!
I'm not saying that everybody should get it, but not everybody needs it, especially based on the
And that
financial.
does what?
And it helps to predict which patients will benefit from chemotherapy based on their
Ah,
nodal status. So it's basically a scoring tool that you use. Let me don't say it's a scoring tool. It's a test that is a genomic test that's being done. It helps to predict and prognosticate how patients would do if they were given chemotherapy. And based on the score that comes back, whether you're pre or post menopausal, the score is different. But the long
ah.
shot, if you're above the score, it means you benefit. If you're below the
Is that
number,
something new?
it's something relatively new.
Okay.
Meaning it's obviously more um it's more available or accessible overseas. It's not locally available. What happens is that the samples are sent overseas, right? Um, but what's more important is that regardless of whether it is available or not, the limitations to availability is what I just told you in terms of the price. Because 4,000 US dollars is expensive here, but it's also expensive in America. That's a lot of money in America, right?
Yeah.
So a lot of radio, sadly, especially in the public sector, that means a lot of patients aren't going to be doing that test. So it's not only the presence or absence of lymph nodes, it's also other things in the histology report, such as the grade of the tumor, meaning how aggressive it is, the receptor status, in terms of whether your estrogen and progesterone receptors and your HER2 new receptors, what they came back as. So certain persons with triple negative and those who are HER2 positive, they are still favorable patients to get chemotherapy, as well as what stage you were at the time, the size of the tumor. So there's a lot of information that I don't know, not even taking into consideration Oncotype DX, which is now the gold standard. What heme oncologists would have made reference to and say, all right, you would probably be better off getting into chemotherapy, even if you are borderline in terms of whether we should give it or not. Because if you give it and you survive, it's either one or two things. Either you didn't need the chemotherapy, so you didn't have any little cells running around in your blood, or B, you had the little cells running around, the chemotherapy worked. But the fact of the matter, if you're alive, it means that we can say the chemotherapy may have worked, right?
Right.
As opposed to saying, well, let's don't give it. And then a year later, you find out that you have a lesion in your lung or a lesion in your ribs. And that is in relation to the previous cancer surgery that you had a year before. So a lot of information with regards to Nadine's case is not there, right?
Right.
But there is new technology to determine whether patients will benefit from chemotherapy, and that's the Oncotype DX test. And that can be, again, just for the samples and stuff to be sent abroad, but it is cost prohibitive, even for patients that have insurance, because you have to pay for that $4,000 upfront,
Right.
right?
Oh boy, doc. I mean, it almost looks like if you don't have money, it's an uphill struggle.
It is an uphill struggle, but I do think that a lot of patients are, even though our figures aren't as good, because we mentioned that more persons present with advanced disease compared to North America. Our screening is not as in terms of numbers is still lower than what we want to achieve. You still find that many patients do well with the limited resources that we have, but we still have margins to do better. And it's not only from the medical side, it's certainly from the side that you are clearly promoting, Sandra, which is the screening. you know
Right.
so I think that what you are doing and what other entities are doing is great. The problem I have, because I am a high achiever, is something that you also mentioned. when it comes to, there's a commercialization when it comes to October.
Mm-hmm.
It's a great
And we're
initiative.
not, it's not computing to persons going out to get
No,
screened.
no. So the point that you made is very valid. That the fact that persons are very excited about breast cancer between the 1st and the
Mm-hmm.
31st of October.
That's
And
correct.
then it dies down, around the middle of November. And then you come the next year, and then I hear people say, yes, I need to go and do my mammogram this month. And I'm like, you don't need to do your mammogram in October, right? The easiest way for you to remember when to do your
Your
mammogram
birthday. Right.
is do it just after your birthday. Don't do it before in case you get some bad news and you start panicking. But just remember, okay, it's my birthday month. Oh, I need to go and do my mammogram after my
Right.
birthday. It's the 16th. If your birthday happens to fall on the 31st of the month or the end of the month, just probably do it the next day, 2 weeks into the next month. But you can use that as a marker if you're of the age to get the screening done. And I think that is something that we have to push because you do see better results, not only locally, internationally, is seen as well, obviously, with stage one versus stage three. There are always exceptions to the rule, which is what we refer to as anecdotal evidence. I know my church sister that had this and she never did well, or my neighbor's friend had this and it didn't do well. There's always going to be, sadly, patients who may have stage one disease, and for some reason, and it might not only be related to the breast cancer, it could be other comorbidities that don't do well. But there's no doubt in my mind, I can categorically say, if you have stage one versus stage three, and you ask me to figure out who you think is going to do better, I'm going to always pick the stage one.
Right.
Um, I'm always going to start the stage one, not only in terms of the actual cancer pathology itself, but also when you take into consideration the cost, which is prohibitive and greater when you're talking about the treatment of stage three disease.
In your estimation and your experience, Doc, what would you say your mental, I don't call it mental toughness, or your ability to accept and act? What role would you say in terms
Um,
of percentage that plays in your survival?
I think so. Obviously, any surgeon, not only me, is very mentally tough. Anybody who's dealing with cancer is mentally tough. I think I'll call her name. Probably the most mentally tough person that I've come across is not even a surgeon. It's Professor Gillian Worf.
Yes.
Right? I think sometimes I look for her for inspiration, and because sadly she sees even worse cases than we do. Right?
Right.
It's hard at times, which is why when I have a relative or a friend who is diagnosed with breast cancer, sometimes I have to take myself away. And that has happened. I've had many relatives and friends, not with breast cancer alone, but with cancer, that have come to me and asked me to treat them. And I think one scenario, all I did was take the person up to the point of surgery, hand it over to the surgeon. When the surgeon was happy with everything, then I continued the management afterwards because I'm human. I am human, and the biggest mistake that any surgeon can make is when there's an emotional attachment to the case, because then you deviate from what is scientifically based protocols, and which is always going to be the best interest of the patient. You start doing things differently, right? I've had this year. I remember I was one of my residents' immediate relatives was shot,
Mhm.
and he wanted to come in on the surgery, and I said you can't come in on the operation because, and he was upset. And then afterwards, when I spoke to him why, he understood fully why. Because he's not going to go in there and do what he should be doing. He's going to go in there, if he has to throw 5 knots, he's going to throw 7. If he,
Right.
this is fine, he's going to then spend an extra 5 minutes looking at it to make sure. He's going to start looking and doing things which he doesn't normally do, and the things that you do normally are the ones that give the best results. So you try to stay neutral. Obviously, you're dealing with people, and you do develop personal relationships with some of your patients. I have relationships and with a lot of my cancer patients, because a lot of my cancer patients are breast cancer patients, where I can say that some of them have become my friends. Right? I've been invited to their birthday parties. I'm looking right now in my office at some gifts that patients have given me, and I can tell you that the gifts are like ornaments that are like, one is a golf club, another one is a golf club and a
I
golf.
know you.
Right, and that's because there's obviously discussions that happen in the office, and they know
Right.
it. And Jamaica is a small place, so I might
Right.
go to Mega Mart, or I might just go somewhere to the pharmacy to get something. And I seen one of my patients, and I end up talking to them. So you try to do set some boundaries to some degree, but some of them, because they're good people, cross those boundaries and become your friends, and that's in a
Mhm.
positive way. And when you recognize that happens, it's great for two reasons. Because the one thing somebody said to me, and I say it to other people now, is I remember one time I saw Professor Joseph Plummer, right, on Tony Trace, and I saw a patient, shouting at him, and he was smiling. And I said, Joseph, how you let the patient just shout at you like that? You continue. He said, a dead patient can't argue, right?
That's right.
So he's like, I've been treating this lady for 11 years. So she's
Mhm.
arguing with me, means she's still here. I did
That's
something
right.
right.
That's one way to look at it.
Yeah. So I've always said that, as long as the patient is alive and he or she is doing well, um, I would take the complaints, because
Mhm.
it's always a win for me, and it's more importantly a win for the patient. Um, so that's how it is, how I look at it.
Mhm. And in terms of the patient now, navigating their treatment, do you think it is when a patient accepts their position versus one who is worrying about everything and then some? Do you think that has a negative or a positive, well, definitely negative reaction in terms of the medication or the procedure
So
working?
there is a, not from my standpoint, and I don't think from a surgeon standpoint, but remember, health is physical, mental, and emotional well-being. I
Right,
do think that, when your parents say that you can speak things into reality,
right.
I do believe that if you have, part of our job, even though I'm not a psychiatrist, is psychology. And that is that you have to make the patient feel comfortable. You don't have to, I say to the patient, I'm not going to lie to you. And that's why it's very important that a relative or a close friend always comes with the patient, especially in the initial phases of the bad news.
Yes,
And then the other thing which I do, which I've learned from other colleagues before me, and I think some colleagues below me do it as well, is I don't speak to patients in private practice, that is, about finances. Me,
right.
I speak to, like, for example, if it's a husband and a wife, I speak to the husband about the finances, just so that the woman doesn't know. He might go home and tell her, because obviously he has to access her insurance and her critical illness. But
Right.
point is, I want to take that emotional and mental, and it goes to converse. If it's a male patient that has cancer, I'm gonna speak to the spouse or the girlfriend or the mother or whoever the next of kin or the person that they brought in the office, because I think that a lot of times, as you said, you realize that it's an expensive venture, and then I also find that there's an element of guilt where
Mhm.
patients feel that, boy, it is, not only is it going to be expensive for me, but I don't want to put my family through this.
Through
My
that stress.
daughter has her college fund, and then they start making decisions,
And
taking.
that's real though, Doc.
Oh, it is real. I'm not.
That
I'm
is
not giving you made
real.
up stories. It is real. So you try to take as much emotional stress away from the patient, right? And that means if it is that you have to call the radiologist, which I do and many colleagues do, and set up the appointment, say, just all I can do is point you in the directions of where you have to go, who you have to go. They will tell you what time you have to go. And if you have any problems, you pick up the phone and call me. Right. And I think that makes those little things make a difference.
Absolutely.
And I had the privilege that I was able to do them, but then patients will come back and say that they realize that not everybody does it, even though I think the majority of people do it. And those things make a difference. And my approach that I have used, and I think I've preached it to many of my residents, and I think I've heard other colleagues preaching it too, is try to treat the patient like how you would treat your mother, your wife, or your sister. If you don't think this is acceptable for those persons, it should not be acceptable for the patient. And I'm not talking about, whether you get surgery at KPH versus in the private sector. I'm talking about in terms of the treatment algorithm or protocols,
Mhm. Yeah, well, you have one big up here. Marlene Dawson said, Mr. Dr. Roberts was my surgeon, September 26, 2012. A job well done at KPH. So you get one big up online. Well, Doc, as we wrap, you know, and I'm not going to say we come to the end of breast cancer. Well, it's now our breast cancer talks. Well, certainly the end of this series, because it was a series of five. And for those persons online who did not get a chance to see all of them, you can go back and watch them because they are posted on the page and they are posted on YouTube as well. Because it's live on YouTube, it's live on Instagram, and it's live on Facebook, and it's also saved on all platforms. So, I mean, we need to continue this conversation, and I may be join for you again, maybe another month down the road. But because it is a serious conversation, and even I just want you to say something, because even as we go through the aftermath of Melissa, breast cancer still continues.
Yeah.
And for those persons who are going through that level of stress and then trying to manage the stress of breast cancer, what word do you have for them at this time? And especially those in
The
those
West.
areas that don't have access. I'm thinking that they may have to find a way, if they're still going through treatment, they may have to find a way to relocate for a minute, you think?
Yeah. So what I can say, I think what Jamaica has gone through. You probably heard from my voice that I don't sound Jamaican. That's because I'm half Jamaican, half Barbadian. Grew up in Barbados, so I never experienced Gilbert. I experienced some of the other stuff that was comparative to Melissa is negligible. No, like the island
Right,
deans and those things. But what I think is really on the positive side of Melissa, which is obviously a worse stand on Gilbert, is that Melissa only affected the western part of the country, as opposed to Gilbert, which affected the entire country because it moved, if you remember, from southeast all the way
right,
down to
straight
Black
straight
Point,
down,
right?
yes.
And why I say that is because I can safely say, because I had one, I work at KPH, and I had a full operative list where we did 3 breast cancer patients yesterday, is that KPH is fully up and running and the breast clinic is fully up and running. And two, I've had Dr. Lindbergh Simpson, who is actually head. I'm the acting head, but he's the head of surgery at KPH. Um, has come up with a plan to take patients from the West that are in that require urgent cases. And this is not only at KPH. This is also a plan that Dr. Newnham, who is the acting head at university, has done. And there has been talks with all of the surgical colleagues across the island, including we've spoken to the surgeons at Black River, Savlamar,
Yes,
Cornwall. So they know on the ground that when patients come to them with not only breast cancer but any urgent cases that cannot wait till next year for surgery, that
right,
you just come in. We're not refusing anyone, because I think the one good thing that we've seen locally in terms of the response to what's happened in the West is that Jamaican people are quite resilient. The humanitarian effort, even though everybody practices this whole bad manism thing and whatever, everybody is showing to have a heart and resilience, and you can see that locally. I'm not even talking about the overseas response, which is also seems to be positive.
right,
Hopefully you realize that many persons are just giving money. There's not question giving care packages. And from the medical standpoint, I know that I had a meeting with Dr. Leopold Powell, who is actually the current head of the ASJ, as well as Dr. Newnham and Dr. Lindbergh Simpson yesterday, and we are fully ready for the cases to come in. Right?
right.
Once our
If
colleagues,
there's anybody online who has folks down in the country, please, I don't know, because they have no connectivity,
yeah.
so they won't be able to see this at any point unless I guess they have Starlink.
But
Um,
Sandra, you know what's the biggest thing? Word,
yes,
word of mouth. It will travel.
that is true, right? So that's why I'm saying to my friends online, if they have if they know of anyone who is going through anything down in the West, and as Doc said, KPH is up and running, and they can well, I don't even know if they have access to their records at this time, because I know there has been damage to Cornwall Regional, and I know there have been damage to Black River Hospital. So I don't know what that is like. So, but we don't want to, they don't want to add to their situation by sitting down with breast cancer while trying to navigate their situation. They may just have to find a way to relocate in Kingston, have it sorted, and then now somehow work out the other back end, because cancer, as you know, is time sensitive, and that will have to be actioned as quickly as possible. Because the truth is, the world doesn't stop because their roof left, or because Melissa came. The truth is, if the breast cancer was already there, they will have to find a way to deal with it. And Kingston is up and running. A friend of mine, it was so funny. I mean, funny but not funny. She sent me a message when she did get some service. She says, "Is it true that there's still internet in Kingston, and that you can still get gas, and that the ATM machines are still working?" And she made it sound like I was in a different world. That's how I realized that they were so detached in Montego Bay, and so I had to fly myself down there and try and help her out and stuff, because it was so it was so you couldn't, when I saw the message, it was like she was in disbelief
Yeah.
that we are here operating as if nothing happened, but that is the truth.
I think there's a sense of guilt when I speak to some people, that they feel that they are not going through the same thing as the persons in the West. And I've had that guilt as well, in terms of, when people ask me overseas, how am I doing? I'm like, I'm good. I'm fine, fortunately. But I think it's also, look at it from a positive, is that because we are fine in the eastern part of the country, we can help those in the West. In
That,
the ways
well,
that,
that is the blessing, that we are in a position to help.
yeah,
Because if all we did mash up, then that would be
yeah.
pandemonium. So I think, in spite of it all, I think we were still spared. We were still spared, so that we are in a position to help our brothers and sisters in the West. So it's 1 hour and 36 minutes. You gave us a lot to chew on. And Doc, as usual, it's always a pleasure to speak to you, because as you always say, you talk about things them, and I so appreciate you. And the thing is, we are working together to make a better situation. Whatever we talk about on this platform, or in any platform at all, it is with an interest to improve whatever situation we currently have, and to educate the fact that, for those of you who are just coming on, that there is a breast oncology center down at the KPH, run by Dr. Copeland and Dr. Roberts, and anybody else, Doc?
Well, just Dr. Copeland primary now, and then
Oh,
mention the
Dr.
one at
Copeland
university.
primary,
Yeah,
and but
and the one at university as
you
well.
are connected to
I'm
it.
still connected because, remember, it's my firm. I'm
Oh, okay,
yeah.
okay,
It's
okay,
the
okay,
same.
okay.
It's a spin off, because
Okay,
Dr.
it's a
Copeland,
spin-off.
even though
Okay,
he's a breast oncologist, remember, he's also a general surgeon. So he's
right.
also one of the consultants on firm too. And then the
Okay,
staff.
and what, and just for the, so that they know what exactly happens at KPH, at the breast oncology clinic.
So it's Tuesdays. It starts in the morning
So
at
it's
8 o'clock.
only Tuesdays,
There's only Tuesdays, barring a public holiday, or the clinic is
right?
closed, which is usually for 2 weeks around Christmas period.
And that's from what hour to what hour?
Well, it starts at 8 o'clock. It ends whenever the last patient has been seen.
Okay, and
Sometimes the
there
staff
is no, there
work
is a
at-
cost, or there is no
no,
cost?
there's no cost. As
There's
long
no
as
cost.
whether you're coming as a new patient or a follow up, there's no cost. If there's affiliated costs, the costs have to do with things that have to be done outside, or things that the patients will have to procure, like a biopsy needle. And I should
Right, and at which point they can use that. That's a good point to say to the general public who is online now, that at Reach to Recovery, we offer each person up to an amount of 150,000 Jamaican dollars, and this $150,000 is not given in cash to you directly. However, It can be drawn down on to do needle biopsy, bone scan, ultrasound. Um, if you want to put it towards your surgery, if you want to put it towards your treatment, if you want to put it towards your medication, whatever you want to put it to, all you need to do is to take a referral from your doctor as well as the invoice from the institution, whether it is the pharmacy that you're going to get your medication, whether it is the doctor, whether it is the institution that's going to do your scan, whether it's a CT scan, a bone scan, or whatever kind of scan. You bring in that invoice and we pay the pharmacy or the location that you brought in the invoice from. We pay them directly and you go and you have your service done. And
Okay.
so that is one of the main reasons why we have the pink run. And for those of you who are unaware, the pink run was rescheduled. It's happening next week, Sunday. That's November 16th. We meet at Emancipation Park at 6 a.m. for warm up. So we are at Emancipation Park from 6 a.m. and the run starts at 6:30. So we have wheelchair, we have runners, and we have walkers. And these funds that I call it donate, because you think you're just, paying to enter a race. That money that you pay, that 2005 or 2002, if you came in as early bird, that money goes directly, or should I say, what's left of it after expenses, what's left of it goes towards individuals, women or men, because remember, men also get breast cancer, and those funds go towards well needed treatment, surgeries, scans, tests. So, on behalf of all of them, for everybody who has already signed up, we are eternally grateful for your contribution. We understand that these are trying times when persons have gone through Melissa, but the truth is, cancer still a keep. That is the truth. So we can't drop one because the other one happened. So we still have to push through. Thank God we were not damaged in Kingston. So we are still able to have the run at a later date. And so also we will be asking the persons who are coming out to run, to take at least one item, because what we're going to do is have a collection drive, because one cocoa full basket, and we have over 15,000 registrants. So I'm thinking if one person, if everybody bring one item, we will have a store full to pass on to Food for the Poor. That's the intention, to hand it over to Food for the Poor and serve whoever, because Food for the Poor goes all over, not just St. Elizabeth or Black River. They go all over, because various other areas that some of them are barely mentioned, they have also been affected too. But because Food for the Poor has a well-oiled machine, we will just hand over the items to Food for the Poor for distribution. So we are thanking you in advance, one, for coming out to walk or run with us. I know the Seventh-day Adventist persons were having my head, because initially we had said it was going to have to be on a Saturday, but as God smiled on us, we were able to get a Sunday, and so we're on Sunday, November 16th. Dr. Roberts, I want to say thank you once again. I know you're a very busy man, but you're always so willing to speak on behalf of all of us, because for those of us who have already experienced breast cancer, and would like to see persons surviving like us, and would like to see persons coming in early stage breast cancer versus late stage breast cancer. We're encouraging everyone out there, don't wait to find a lump. Be proactive. If you are at 40 years old, go in to get your mammogram done, because sometimes it does not show up in a lump. It comes in like granules of sand that can only be picked up by the imaging. Am I correct, Doc?
You're correct.
Right? And so you want to go in to get screened early. And if you have breast cancer in your family, or if you are high risk for breast cancer, meaning obesity, having persons in your family having breast cancer. What else are the high risk, doc?
If you had previous biopsies that show that you're at increased risk, if any
Right?
models that we use show that you have a lifetime risk that is over 20%, because the lifetime risk in Jamaica's average is between 8 and 12%, meaning
That's
one in
correct.
every 12 or one in every 8 to 12 women would get it. And then also if you had a previous chest wall radiotherapy, those are some of the factors. Or if you have a genetic predisposition, you had a genetic testing for another reason that shows that you have the mutations in the BRCA1 or 2 genes, those are what you would call high risk patients. But bear in mind, the majority of persons wouldn't have any of those things. They would be average risk. And,
Right.
and that's what I would
You know
say.
what I'd love to see, doc? I would love to see breast cancer treated similarly to hypertension and diabetes, so that when you go into the office, certain questions are asked about family history. Because I have not really seen that. I have, prior to me having breast cancer, I have never been really asked about my family history of anything of that nature. So I'm praying and hoping that one day we'll get there, and people's families, his family history will be taken, just like how when you go to the office now, persons asking you about COVID, if you have ever had COVID, or if you have any symptoms of COVID or anything like that. Due to the prevalence of breast cancer, we are hoping that we will eventually get to that stage where it's like a common question to ask. So I know you'll work on that in the quiet.
And I know you will call on me and again.
And you know I'll be pressing, right?
I
So
know.
once again, oh, somebody says, big up, Doc.
Thank you.
Yeah, oh, that was Marlene, yes. So as I said, keep safe. Thank you so much for joining. We do know that you could have been anywhere else, but you joined us tonight. And for those persons who signed on late, remember it will be on permanently on YouTube, and it will also be on our Facebook pages. So thank you so much for joining. Have a good night, Doc. I hope everything. I know you had to do some scrambling during, Melissa. I hope everything is okay down by the office now and all is well, because I know we are going to be going through tough times. I know your load is about to get heavier. So we just have to pray for you. Pray for you and everybody down at KPH for strength, vim and vigor to go through all that is to come. Because trust me, although we were not physically affected, I know we are going to get some of the traffic from
Yeah.
the country.
I mean, we started getting that already, but many thanks.
Yes, so we continue to pray for you, and we continue to pray for our friends in the West, as well as some persons. I know some persons got damaged in St. Thomas as well, and some other areas. And of course, some people suffered some flooding and some roof damage right here in Kingston. But thank God it was not a catastrophic event. So we give thanks. And so I see you hopefully out on at Emancipation Park at on November 16th at 6 o'clock in the AM. And Elaine will be there to cheer us up and sing some nice words for us on the morning. So, take care. Have a good night. Have a good week. or should I say weekend, because it is Thursday. And, we just want to give God thanks again for sparing us. For those who had family that lost their life, once again, we say our sincere condolences and we grieve with you and for you. Thank you. Have a good night. And we will, because this is the end of the series, but I promise come next year, because this is our last one for the year. Come next year, we're hoping to have at least one conversation per month, maybe on, healthy lifestyle or other aspects of, trying to navigate this whole breast cancer situation on a more positive note. So have a Merry Christmas, because I won't see you again online until in the new year. So see you, Doc. Love you. All the best.
All the best. Good
And
night.
all the best for my friends online. Good night. Have a good night.